Hello, everybody. Dear Organization Committee of the APCIS Congress, I want to thank you for your kind invitation as a speaker. And this is the topic of my talk, angiogram-based physiological assessment. Should we prepare? And along this talk, I will try to answer this question. These are my disclosures. And first, we should remember what is functional angiography. Overall, all functional angiography methods are based on a three-dimensional reconstruction of the target coronary vessel using either computed tomography or invasive coronary angiography. And over the three-dimensional model, computational fluid dynamics or advanced mathematical formulas are applied to simulate the hyperemic coronary flow through the target lesion, and therefore estimating what would be the invasive FFR value, but importantly, avoiding the need of pressure wires and hyperemic drugs. And to put this in context, let's start with a case demonstration with one of the currently available functional angiography techniques, the quantitative flow ratio. So first, with this technique, we need to choose two optimal angiography views that should be separate more than 25 degrees. And after that, then we need to find an optimal end diastolic frame in both views, in which the vessel, the target vessel is fully opacified by contrast without significant overlapping of the vessels. And for doing that, the current software uses the EKG signal to automatically detect the end diastolic frame. Then we indicate same anatomical landmarks in both views that the software will use to match every segment point in the process of the three-dimensional reconstruction. And after that, we select the segment of the vessel that we want to analyze with QFR, indicating a proximal point and also the landing zone. And after that, the software automatically trace the contours of the vessel in both views. And we need to pay special attention to modify these contours if it is necessary, as you can see here in this example. And I will say at this step that the higher the quality of the angiography image, the lesser the number of corrections that we will need to do. And then after doing these manual corrections of the contours, we obtain the preliminary 3D model of the vessel, and also the diameter function in which we can see the minimal and the maximal reference diameters that should have a similar path. And after that, the final 3D model and the anatomical parameters of the lesion are obtained. We should check at this point that the main reference diameter in red fit the healthy proximal and distal segments of the vessel. And after that, the software automatically performs the frame counting that the contrast takes to travel the segment of the vessel. After that, we indicate the type of the vessel that we are analyzing. And finally, we obtain the QFR value, which in this case is 0.75, indicating in the same manner that FFR, that this lesion is physiologically severe. And then you see how we can perform a fast functional angiogram-based evaluation of the coronary lesions, that in the case that I show you, I took less than 3 minutes in performing the QFR analysis. And in the FAVOR2 international study, it has been demonstrated that in expert hands, the time to QFR analysis is around 5 minutes, which is lesser, significantly lesser time consuming compared to invasive FFR, which takes around 7 minutes. Therefore, considering that functional angiography doesn't need introducing a pressure wire into the coronary vessel, doesn't need hyperemic drugs like adenosine, and that on expert hands, these methods facilitate a fast computation of FFR, we can anticipate that the functional angiography can be safer and can be faster than invasive FFR. And in this background, by being aware of the limitations of the conventional angiography and the limitations of FFR, we can easily infer the multiple advantage of functional angiography. Look, conventional angiography has a well-demonstrated limitations of the functional accuracy, and on the other hand, invasive FFR requires coronary instrumentation, requires hyperemic drugs that frequently cause patient discomfort, requires also additional time, and has an additional immediate cost. And that is why it should not be surprising that the adoption of FFR in the real practice around the world is still very low, despite the highest level of recommendation in the current clinical practice guidelines. So considering all these mentioned advantages of functional angiography, I will say, yes, we should be prepared for an angiogram-based physiological assessment because it is fast, it is safe, it is relatively easy, and may substantially increase the adoption of physiology-guided revascularization in the real practice. Let's see now an overall briefly summary of the several methods of functional angiography that are available nowadays. FFR from computed tomography is historically the first one angiogram-based method that has been developed to estimate FFR. And this method has demonstrated that correlates very well with invasive FFR and accounts with a large body of evidence along the last decade. FFR-CT has demonstrated its clinical value by predicting clinical outcomes. And then it is accepted that the integration of FFR-CT in the diagnostic workflow may help in the clinical decision making. On the other hand, on the grounds of invasive angiography, we have several techniques. QFR is one of the first developed method to predict FFR using invasive coronary angiography. And importantly, QFR is so far the angiogram-based method that accounts with a larger body of evidence and in which I want to highlight these two prospective international favor two studies that demonstrated that online QFR calculation is feasible and is more accurate than conventional angiography in predicting the invasive FFR. But we also have at least 3 other techniques like QFR. This method is, for example, named FFR angio, which at a difference to QFR, make a 3-dimensional reconstruction of the whole coronary tree and also has demonstrated a high agreement and a high correlation with the wire-based FFR. This other one is named vessel FFR. This is similar to QFR because make a single vessel analysis using 2 separate angiogram views. And this method has also demonstrated recently that is superior to conventional angiography parameters in predicting the wire-based fractional flow reserve. This other is the most recently developed angiogram-based technique is named CA-FFR, and is similar to QFR because also makes a single vessel analysis using 2 angiogram views. But at a difference with QFR, which applies advanced mathematical algorithms, CA-FFR uses computational fluid dynamics to simulate the coronary flow. And this angiogram-based method has also demonstrated an excellent correlation and a good agreement with the wire-based FFR. So in the same manner that we have currently several wire-based pressure indices, one from each company in the case of the resting indices, each of them with small differences in the calculation of the index. The same occurs with the functional coronary angiography techniques. Currently, we have at least 5 different methods, each one from a different company. Each of them applies different principles, but at the end, all of them provides a single pressure index, and all of them have demonstrated a good agreement with the wire-based FFR. And importantly, when we look at the scientific evidence, we can be aware that there is a large body of scientific studies supporting the feasibility and the accuracy of all these image-based coronary physiology techniques. In fact, when we introduce, for example, the name of QFR in PubMed, which is the one among the invasive angiography-based methods with a larger body of evidence, you can see the large number of studies with this technique and the remarkable increase in the number of the studies along the last 5 years. Therefore, in my answer to this question, should we prepare for an angiogram-based physiological assessment? I will say again, yes. And I want to add these other reasons. Functional coronary angiography has demonstrated a high accuracy to estimate FFR. We are witnessing a hyperbolic increasing of the scientific evidence related with these methods. And we have also a remarkable advantage of these techniques over the wire-based FFR, and we are witnessing a remarkable interest from different commercial companies in these methods. Let's see now the clinical value of functional angiography in other clinical subsets beyond stable angina or chronic coronary syndromes. So let me show you 2 clinical cases. This is a 60-year-old male, a smoker, that presented with an inferior STEMI, and the culprit vessel, which was the right coronary artery, was successfully treated with primary PCI. But in the same acute angiography during the primary PCI, the angiography revealed a severe stenosis in the mid-left circumflex. And in this patient, we performed an invasive functional assessment with FFR in the left circumflex at a second procedure 2 days later. And we obtained a non-ischemic FFR value of 0.93, and therefore we deferred the PCI in this non-culprit vessel. But interestingly, the QFR analysis using the same acute angiography, not the second one, revealed also a non-ischemic QFR value almost equal to FFR 0.92. And this case illustrates very well how the functional lesion assessment of this stenosis with functional angiography, but using the acute angiography, will avoid unnecessary second invasive procedure in this patient with STEMI and multivessel disease. And this approach with QFR using the acute angiography compared to wire-based FFR at a second procedure has shown to be feasible and accurate, and potentially can avoid a significant number of second invasive procedures. Furthermore, it has been reported that in STEMI patients in whom non-culprit lesions were left untreated, those patients with non-culprit lesions showing a QFR value below 0.80 were at a significant higher risk of adverse clinical outcomes at 5 years follow-up compared to those patients with non-culprit lesions with a QFR value more than 0.80. In addition, it has been recently reported that a pan-coronary functional assessment using QFR in patients with any type of acute coronary syndrome provides a better clinical risk stratification at long term. Look, patients with a post-PCI QFR value below 0.89 in the culprit vessel, or with a QFR value below 0.85 in non-culprit lesions are at a significant higher risk of adverse clinical outcomes. So in the acute coronary syndrome setting, functional angiography methods are useful to evaluate the functional significance of non-culprit lesions using the acute angiography and avoiding unnecessary second invasive procedures. And therefore, these techniques may shorten the hospital stay and allow us to identify patients that remain at a higher risk of adverse clinical outcomes after PCI of the culprit vessel. This other case is about an 80-year-old male with a chronic renal failure and a severe aortic stenosis that presented with a stable angina, and in whom the coronary angiography revealed an ambiguous lesion in the proximal segment of the LID. Because of the borderline hemodynamic condition of this patient with a severe aortic stenosis, and also the presence of chronic renal failure, we prefer to avoid an invasive wire-based assessment of the LID stenosis. And instead, we did a functional lesion assessment using functional angiography with QFR, and we obtained a QFR value of 0.83. And therefore, we decided to defer intervention in the LID stenosis, and we focus on the treatment of the aortic valve disease. Therefore, when we are facing a population with an important risk of a significant decrease in systolic blood pressure with adenosine infusion during FFR assessment, the functional angiography techniques may gain a lot of interest in the real practice in this population, in these patients with severe aortic stenosis. And the accuracy of these techniques in the setting of aortic stenosis, and particularly with QFR, has been reported to be good. And currently, we have at least three different studies from different researcher groups that has demonstrated a good diagnostic performance of QFR in the pre-TAVI setting using pre-TAVI FFR or post-TAVI FFR as the reference standard. Therefore, I would say that functional angiography techniques are particularly of high interest in the setting of aortic stenosis because allows the functional assessment of the coronary lesions without the risk of significant hypotension associated to adenosine, and because it may facilitate the clinical decision-making in the workflow in this population. So in answering to this question, yes, we should be prepared for angiogram-based physiological assessment. I will add another reason. The functional angiography techniques has demonstrated feasibility and accuracy in other clinical scenarios beyond stable angina, like the acute coronary syndromes and aortic stenosis. And finally, I want to remark that we have currently 2 randomized clinical trials with QFR that will show us if this technique is safe in terms of clinical outcomes. These trials are the FAVOR 3 China and the FAVOR 3 Europe Japan that have both a large population size and that are testing the superiority of QFR guided PCI over angiography guided PCI in the case of the FAVOR 3 China, or and the non-inferiority of QFR guided PCI compared to FFR guided PCI in the case of the FAVOR 3 Europe. So therefore, I would say definitely yes, we should be prepared for an angiogram-based physiological assessment. And I would add this another reason. Randomized clinical multi-center trials are coming soon. And these are all my reasons why I would say definitely yes, we should be prepared for an angiogram-based physiological assessment. And many thanks for your attention.